normal cell damage through DNA, the blood vessel is damaged and it leads to hypoxia, then leads to fibrosis. In brain specifically, the neural progenitor cells are also damaged, again lead to more cognitive damage. We say that radiation-induced adverse effects recover within 6 months. But if it persists after 6 months, then we label it as necrosis and label them as a candidate of HBOT.
Hello, everyone, and thanks for joining the session. Let me quickly introduce myself. My name is Arpan Talwar, and I'm one of the co-founders at HBOT India. Today, our webinar session is on the topic of role of hyperbaric oxygen therapy in radiation necrosis. We thank all our participants who have joined, and we would also like to thank Dr. Mandeep Malhotra, who is also one of our chief mentors, who has joined us today to take us through this topic and enlighten us a bit on the role of hyperbaric oxygen therapy in radiation necrosis. Dr. Mandeep, we would like you to lead the session. Thank you very much. Dr. Mandeep, would you like to take it forward from here?
Thank you, Arpan. A very good evening to all of you. So me being from an oncology background, so we are talking about radiation necrosis. And being a surgical oncologist, I just want to introduce the fact that why am I talking about HBOT? So last year I did my hyperbaric technology certification from South Carolina. Arpan has been really the instrument behind the HBOT India and our hyperbaric setup in Gurgaon. So we have a dual chamber basically. We can have two patients at a time, 3 ATA machine in our center. And today we'll be talking about the role of HBOT in radiation necrosis. So as a lot of my esteemed seniors, colleagues, my fraternity members are there, so I will limit myself to exactly the role of hyperbaric oxygen in radiation necrosis and what is the literature behind it at this point of time. So radiation therapy, as we all know, is one of the very powerful tools of fighting cancer, and it sometimes every cancer treatment has some unintended consequences. Surgery also has this, chemotherapy also has this. So one of this is the radiation necrosis, a delayed injury that can affect normal soft tissues and bones. So normally it manifests in three ways. Either it's in bone and jaw. Osteoradionecrosis is one of the most common complications, especially after treating head and neck cancer. And another part is manifestation is a soft tissue damage, especially soft tissues of neck, chest, or pelvis, leading to ulcers, pain, difficulty in swallowing, radiation proctitis, radiation cystitis, and especially after when we are treating brain cancers, brain tumors, so post-surgery, post-radiation, sometimes we have radiation necrosis in the around the tumor field, or when we are giving whole brain radiation, so it can cause seizures, weakness, and cognitive decline also. So what is the pathophysiology of radiation necrosis? So initial damage by the radiation is a damage of at the DNA level of the cell, and if it is severe enough, that is the normal cells and even the cancer cells, that is how it works, the cells will not be able to recover. Radiation also damages especially the capillary beds, arterioles, and lead to the relative hypoxia of which is results in characteristic fibrosis. So basically the normal cell damage through DNA, then the blood vessel or vasculature is damaged and it leads to hypoxia. This hypoxia then leads to fibrosis, and this damaged tissue which has lack of capillaries, lack of arterioles, there is increase in stoma, and that gives tissue its fibrotic appearance and texture. And such hypoxic tissue, and which becomes further distant from the oxygen supply from the red blood cells, it also again causes decreased number of capillary beds. Even when this injury stimulates the from the inherent body's reaction, the VEGF is released and it starts developing new angiogenesis. So, but this again is a disorganized vascular growth leading to telangiectasia formations, which are prone to bleeding, and then bleeding thrombosis again causes tissue necrosis, again causes hypoxia. And in brain specifically, the neural progenitor cells are also injured or damaged, that again lead to more cognitive damage. That is the pathophysiology behind radiation necrosis. So coming to the brain and soft tissue radio necrosis, normally we say that radiation induced adverse effects or side effects, they normally recover within 6 months. But if it persists after 6 months to several years, then we intend this kind of treatment or hyperbaric treatment to radiation adverse effects. And it usually occurs within first 1 to 2 years. That is when it occurs, and that is when the maximum benefit of hyperbaric is also there. The incidence of radiation necrosis is around 2.4 to 24% in various studies. My esteemed radiation fraternity knows this much better. And again, the brain MRI can help us differentiate between a recurrence or a post radiation adverse effects. So, whenever we are looking into hyperbaric treatment, we have to be sure that we are not giving hyperbaric in tumor beds. So, in tumor beds, hyperbaric can stimulate angiogenesis, and it can also adversely affect the cancer spread. The soft tissue necrosis, again, it's the same dictum that if it the radiation changes or necrosis present persists beyond 6 months to several years, then we label it as necrosis, and we label them as a candidate of HBOT. The incidence of soft tissue radionecrosis varies between 3 to 5%, or some studies also say around 7 to 10%, but that is basic literature around it. And most of the times the symptoms resolves without treatment, like without the HBOT treatment, the conventional treatment is able to manage. But again, the dictum is that if it is persisting for more than 6 months, then it is a chronic problem and HBOT will benefit. Soft tissue necrosis of where hyperbaric has benefited is head and neck cancers, breast, chest wall, pelvic organs, bladder, and rectum. Again, the factors which contribute to increased radionecrosis is malnutrition, increased age of patient, a microvascular or a macrovascular disease, tobacco use, diabetes, repeated trauma or pressure injuries at certain sites can also contribute towards radionecrosis of that area. So how does HBOT contribute? So HBOT works on the Henry's law principle. So what is Henry's law? Henry's law is what is our Pepsi, soda water everywhere. So whenever we have a gas in, whenever there is a pressure is increased, the dissolvability of gas in liquid is increased. So that is what is our soda water is, that we put increased pressure in the uh, soda water, so the dissolvability of carbon dioxide in the water is increased. Similarly, whenever we are, so in HBOT, we put the patient in a pressurized chamber and ask the patient to inhale oxygen. So apart from the oxygen which saturates the hemoglobin, the plasma, the blood plasma oxygen level rises. So this blood plasma oxygen level, if I increase the atmospheric pressure to around 2 atmosphere, that's 2 atmospheric pressure, the change in blood plasma oxygen level is around 7 to 9 times. So this 7 to 9 times increase oxygen in the blood plasma, and this is one of the most diffusible oxygen. So basically, from the blood, that is the plasma, it diffuses to the interstitial fluid, and it reaches to the affected cells much more easily as vis-a-vis the hemoglobin bound. So hemoglobin bound oxygen is anywhere there. HBOT works on the principle of increasing the plasma oxygen content, and this plasma oxygen content then reaches the tissue in need and helps in tissue repair. So as radiation necrosis is a part of cognitive and ischemic process which leads to cellular death, so this ischemic reperfusion injury phenomenon is there. So hyperbaric oxygen helps to restore normal cellular function and aid in the repair of ischemic or damaged tissue. Whether HBOT has a significant role, and whether we have confirmed it in double blind placebo controlled trials, no, not till now. But there are many case studies, prospective studies, which have demonstrated clear benefit of adding HBOT to the standard medical treatment, which is going on, which is prescribed by the radiation oncology colleagues. So HBOT again then helps in promoting tissue healing, improved angiogenesis, uh, better tissue perfusion, and this reduces tissue edema, enhances collagen synthesis, fibroblasts, and even the neural, uh, the nerve cells which are under praxia, which are not completely dead. It also helps in neural recovery in a much significant way. So this is the methodology which we follow in the HBOT, and that is the standard methodology described in the literature. That HBOT is done in at 2 to 3 atmospheric pressure for 90 to 110 minutes, and in between we give a break of 5 to 10 minutes, and then if in every 30-minute cycle. So if I have a 90-minute cycle, so I would have a break once or twice, and then we give the break, then we again increase the oxygen. So first of all, it reduces oxygen toxicity. Secondly, it also it is there's a lot of literature from Israel which says that it also increases the tissue perfusion. A pressure of 2.4 ATA is where the maximum benefit is, and beyond that, obviously there is high incidence. The chances of oxygen seizures are higher. We also follow the same principle that we start from 1.5, slowly we increase it to 288, then to 2.2, 2.5, and 2.4 ATM. That is how we do it gradually, so that we decrease the incidence of barotrauma. And then before putting the patient in HBOT chamber, we definitely ask about claustrophobia. We definitely ask about we do a check X-ray, ECG, and look into whether the patient is under drugs like bleomycin, which can cause pulmonofibrosis, or a cisplatin, which can increase the bladder toxicity. So normally, the benefit is basically seen around 20 treatments. So after 20 treatments, that is when we can assess whether there is some benefit or not. And if there is some benefit, then we would recommend that the patient should go more for 30 to 40 more sessions. And that is where the benefit of HBOT actually plateaus. And this improvement is basically clinically manifested with more elasticity in the fibrotic tissue. Granulation is improved, is in the wound bed is much better. The xerostomia is much better. The saliva starts, a bit of enhancement in saliva production is there. And specifically the radiation cystitis, the chances that the literature says around 70 to 80% recovery in radiation cystitis is seen with adding hyperbaric. Coming to the osteoradionecrosis, which is again relatively rare but very potentially painful and debilitating consequence of head and neck radiotherapy, and it causes aesthetic changes, it causes intractable pain, difficulty in mastication, speech, and swallow. It is basically characterized by exposed, irritated bone that fails to heal even after 3 months of post radiation or absence of radiation. And we have to again make sure that there is no residual tumor or a recurrent tumor. So Schwartz and Kagan actually classified this osteoradionecrosis in 3 stages. A stage 1 is characterized by minimal soft tissue ulceration and limited exposure of cortical bone. In stage 2, basically the ischemic necrosis progresses towards mandibular cortex, underlying medullary bone. And 2A, there is a minimal soft tissue ulceration. 2B, it states as presence of orocutaneous fistula or mild soft tissue necrosis. Stage 3, there is a full thickness involvement of bone, including the inferior border with pathological or potentially pathological fractures. Majority of patients, stage 1, are managed by medical management, whereas stage 2, the surgical approach is generally involved. And hyperbaric is a good technique when we is beneficial when we involve it with surgical technique and a good surgical technique. And normally we follow Dr. Mark's protocol of osteoradionecrosis. That is, he has demonstrated that benefit of treating patient is that first initial 20 to 30 sessions of hyperbaric is given, then the surgery is attempted, and after the surgery additional 10 sessions are added to promote healing and graft uptake. And in his study, it is shown that there is a post surgery, the incidence of wound adhesions goes down to 11% from 50%. The reduction of infection goes down from 24% to 6%, and delayed healing is also just 11%. In addition to the HBOT, it is basically the pentoclo regime, which is generally added, and it is basically consists of pentoxifylline to increase the blood flow. Tocopherol is vitamin E, and it acts as free radical scavenger, and clotronate actually is which increases the bone osteogenesis. So this is how we go about treating osteoradionecrosis, and so basically it's a recent initiative, and I also personally feel that hyperbaric oxygen can have, or it has a certain role in uh, treating the adverse effects of radiation. Recently, I also read about a paper in which specifically for post radiation induced brain necrosis, in which they have added Avastin. So Avastin basically decreases the VEGF, and over that the HBOT is done. So it also promotes better healing and better recovery and even better cognitive functions. And also, the limitation of HBOT is that it will promote angiogenesis. So if we add Avastin in post, so majority of it is this post malignancy. So Avastin with HBOT would actually help us to counter the HBOT induced angiogenesis, and also prevent the speculated what we say that HBOT can uh, harm if there is a residual cancer or a recurrent cancer. Thank you.
Thank you so much, Dr. Mandeep. And to all our esteemed guests, if there are any questions, we would really appreciate you to please share your questions in the Q&A section. Okay, so yeah, we have a question, Dr. Mandeep. The question was, is it used for acute radiation injury?
Normally, HBOT for acute radiation injury, the data is very limited. Majority of times, HBOT is used for chronic radiation injuries. Acute radiation injury, we really have limited experience about it. Also, the important part of acute radiation injury is that we have to be sure that there is no cancer or recurrence or something like that. So that is another factor why HBOT is normally not recommended in acute radiation situations.
Thanks, Dr. Mandeep. The second follow-on question that we have is the cost for 20 number of sessions. Generally, the cost of one session comes to 4,500 rupees per session, which is multiplied by 20. So whatever number that comes is the cost of 20 sessions. And we would also like to share that some patients that the doctors feel that are underprivileged and could not afford the treatment, we do have another non-profit organization associated with that, where we try to help the patients, but those patients are well evaluated by the particular NGO. Hope that answers the question. We just wanted to share two important pointers. The center that we have in Delhi is in Gurgaon, while we are also in the process of signing up with other centers across India. So as we speak, we have signed up with 6 different centers in India, and we are hoping to increase our numbers follow on. So HBOT India would eventually be a physical as well as a digital platform for the spread of knowledge of hyperbaric oxygen. And we, along with our partner centers across India, we are also happy to conduct any studies, trials together with the doctors if there is a particular interest around a certain category of patients.
Any patients who are in Delhi, we definitely connected with the Apollo Center. And so,
yes, so we are in very good discussions with Dr. Tarun as well. So if there are any patients in that part of the city, we would instead suggest that patients can conduct their sessions at Apollo. And if they're at this part of the city, we would be happy to take the patient there. All right. To all the guests today, all the doctors, our partners, everyone who has joined the session, a big thanks from our side for joining this session. Dr. Mandeep, thank you so much for the time that you have spared for this. And we shall carry forward this series of webinars into a lot of upcoming newer sessions in time to come. With more insights that we have on hyperbaric, with more research that comes forward, we would conduct this series of webinars to share that information and knowledge with everyone. Till the time we connect next, thank you so much once again and have a great time.